I'm going to stand here. Can you hear me and see? Because I'm going to, at some points, refer to my slides, and at some points, I'll be telling you a story. I'm going to talk specifically about the impacts of racism on health, with frameworks, definitions, and if we have time, and if I speak quickly enough, some data. Out of respect to the time, we'll decide when we get there what we're going to do. So the frameworks are going to be, I'm going to first start talking about levels of health intervention and illustrate that with a cartoon allegory. Then I'm going to shift into a discussion specifically of racism, provide a definition, describe racism on 3 levels, and illustrate that with a teaching story, a Gardner's tale allegory. And then we will get into the data. And here's a cartoon, and here we go. Whoops! Boom! Somebody has just fallen off of the cliff of good health. And if that were you or somebody in your family, you would be delighted to find an ambulance there at the bottom of the cliff to speed you on to care. But if we're concerned about other people who may come along that cliff, if we're concerned about community health or public health, population health, we might well ask ourselves, what can we put in place as a health intervention besides just stationing lots of ambulances there at the bottom of the cliff? So somebody's going to say, I know, let's put a net halfway down. Even if people fall, they won't get crunched up at the bottom, right? That's a good idea, except that we all recognize that nets have holes in them. So some people might fall through the cracks, but somebody else will say, well, let's make it a trampoline halfway down, no holes. But even if you have a trampoline halfway down that cliff, you might end up with lots of people just bouncing up and down at half functionality, not able to get back to the top of the cliff. So what else could we put in place as a health intervention? Well, somebody else is going to say, I know, let's put a fence at the edge of the cliff to keep people from falling in the first place. And that's a great idea. But you know, it's going to have to be a very, very strong fence if there's a lot of population pressure against it. So what else can we do as a health intervention? Well, maybe we can move the people away from the edge of the cliff. So I'm going to name these interventions that I've described so far, where the ambulance at the bottom of the cliff represents medical care, and what we in public health describe as tertiary prevention. In public health, we talk about 3 levels of prevention: primary, secondary, tertiary. Tertiary prevention is when you prevent complications from disease that's already in place. So if you prevent the amputations from diabetes, that type of thing. So that's our ambulance. The net, or trampoline halfway down, these are our safety net programs, and secondary prevention, which is early detection, our screening programs. The fence represents primary prevention, keeping things from happening in the first place, so that might be immunization. And moving the population away from the edge of the cliff is what is now being described as addressing the social determinants of health, which include our neighborhood conditions and whether you're in a food desert or not, and how the billboards are. It includes poverty, it includes educational opportunities, all of those things outside the health sector that are creating illness or maintaining health. So if we were thinking about infant mortality, which is a huge problem for the African American community, 2.5 times the infant mortality rate for blacks and whites. Infant mortality is when our babies die before their first birthday. You know, you hear infant mortality, but each statistic is a child dying before their first birthday. Well, if we were thinking about infant mortality and this cliff, the ambulance, these would be our neonatal intensive care units. The net or trampoline, that would be prenatal care. You know, we'll get them into prenatal care. The fence might be some nutrition supplemental programs, like our Women, Infants, and Children WIC programs. Moving the population away from the edge of the cliff might be having excellent schools, so our young girls weren't having babies as early, but keeping on and going on into careers. So, you know, this cliff is very nice, and we could have a community meeting about this. How should we be spending our health resources in Maryland? We could do a lot with this, but so far, it has a fatal flaw, which is that so far, the cliff has not talked about how health disparities arise. So I want you to keep the cliff in the back of your mind, but we're going to shift gears for just a moment to ask, how do health disparities arise? And then we'll come back to the cliff. So how do health disparities arise? Well, especially with regard to racial ethnic health disparities, we have lots of evidence about differences in the quality of care received within the healthcare system. There was an Institute of Medicine report published in 2002 called Unequal Treatment, which pulled together, at that time it was hundreds of studies, now we have thousands of studies, documenting the differences in how vigorously you might be treated for heart disease, depending on your race, or how much pain medication you would get in an emergency room if you came in with a broken lung bone, depending on your race. But even those people on that Institute of Medicine panel who wrote that report, even they said it's not just what happens within the system. Clearly there's another level at which health disparities arise, that's access to the system in the first place. But then we have to go beyond that to acknowledge a third level, which is differences in the conditions of our lives. Differences in our life opportunities, exposures, and stresses that are making some individuals and communities sicker than others in the first place. And when you think about these three levels at which health disparities arise, differences in quality of care, differences in access to care, or differences in underlying exposures and opportunities, really it's like a big pyramid. The huge base of it is with differences in the conditions of our lives. Then you have sicker people, sometimes frustrated because of limited access to the healthcare system. And then even the lucky ones who get into the system are sometimes further injured because of differences in quality of care. So now, remembering those three levels at which health disparities arise, and am I talking too quickly? I'm trying, because I want to share the data with you. So that's why I'm going so fast. But so thinking about those three levels at which health disparities arise, we are going to go back to our cliff now. But now we're going to realize that we are not dealing with a flat, two-dimensional cliff, but actually we're dealing with a three-dimensional cliff. Can you guys see? So we're dealing with a three-dimensional cliff, and maybe there's an ambulance up here close, but maybe that ambulance has a flat tire. So it's slow or goes off in the wrong direction. Or maybe there's no ambulance there at all. Maybe there's no net, nor fence. And you know what? Usually at those parts of the cliff, the population is being pushed closer to the edge. So now I'm going to label this three-dimensional cliff with how health disparities arise, where the differences in quality of care, that's represented by the ambulance that's there, but it's slow or goes off in the wrong direction because it has a flat tire. The differences in access to care, that's no ambulance, no net, no fence. And the differences in the underlying exposures and opportunities, that's the closer proximity of that green population to the edge. Now here I'm going to make a distinction between what many people talk about as addressing the social determinants of health, which we described as moving the population away from the edge of the cliff, and something else. Because now we have to ask the question, now that we recognize we're dealing with a three-dimensional cliff, how did the cliff become three-dimensional, right? And that's usually historical injustices. We just talked about the transatlantic slave trade. Historical injustices that are perpetuated by present-day contemporary structural factors. But given that we have a three-dimensional cliff, we have to ask ourselves some more questions. Why are there differences in how resources are still distributed along that cliff face? And why are there differences in who's found at different parts of the cliff? Why are the oranges back there and away from the edge and the greenies being pushed closer to the edge over on this side? And when you start addressing those kinds of questions, it's no longer about addressing the social determinants of health, like poverty and all. It's addressing the social determinants of equity, which are in systems of power. They're in systems that can distribute resources and distribute populations. And so these are our isms: racism, sexism, economic systems like capitalism, and the like. So what I have done with this clip very quickly is to distill three dimensions of health intervention. And all of these are important, and all of these are active. The first dimension, which if you think about a one-dimensional thing, that's a line. The first dimension, health services, we can display as a line along the cliff face. That's our ambulance, net, fence. This is, when you say health anywhere in this country, people will complete your thought for you and say health care, right? And when we talked about health reform, it's health care reform, and this is what we were talking about. And it's very important. We need universal access to high-quality health care, ambulances, nets, and fences. But we have already recognized that that in and of itself is not going to produce a large and sustained improvement in health outcomes or address inequities, right? We need to acknowledge that we have to move the people away from the edge of the cliff, or else they'll be breaking through any fences that we create. We need to address the social determinants of health, including poverty. And we have to recognize that, yes, we are dealing with a three-dimensional cliff, so we have to go into three-dimensional space and acknowledge and address the social determinants of equity, including racism, if we're going to achieve social justice and eliminate health disparities. So that's the first framework. Okay. Now we're going to say why racism and other, sometimes in some audiences, that's my intro to why I'm even talking about racism as a physician and a public health person, right? Here's another quick way, why racism? If we're going to be serious about eliminating racial ethnic disparities in health, we need to figure out what are the fundamental causes. And as an epidemiologist, if I'm looking at race-associated differences, I'm going to ask myself, what is race? That variable measuring. And when we look at it, it's only a rough proxy for social class, rougher for culture, and meaningless, I would say, for genes. Very quickly, we know that people of color in this country are overrepresented in poverty, but the majority of poor people in this country are white. Not all black people are poor, so there's not a one-to-one correspondence between poverty and blackness. So that's what I mean when I say race is a rough proxy for social class. When you get to culture, there's not one Hispanic culture, there's not one Asian culture, there's not one black culture, there's not one white culture. And people who are called black could have just immigrated from Haiti or got off in a plane from Ethiopia or been raised in the rural south or the urban north and have very different cultures. And then when we get to genes, race is meaningless for genes. There is genetic variability on the planet, yes. It's geographically based. There's genetic variability in this room. There's genetic variability in our families. But the pie slicer that we call race is not capturing that genetic variability. I could talk to you for an hour for that, but I'm going really fast, right? So if I say that race is only a rough proxy for social class, rougher for culture, and meaningless for genes, the question that we need to answer is, why is it such a good predictor of health outcomes in this country? Well, what does it measure more precisely? It captures the social classification of people in our race-conscious society, so that the same race that gets checked off for you when you are admitted to a hospital by a medical admitting clerk, and that becomes part of a health statistic, that is the same race that a taxi driver notices, or a police officer, or a teacher in a classroom, or a judge in a courtroom, and it is that race that has profound impacts on our life experiences and life opportunities, and it's that race on which racism is operating, and therefore I and many others in this room hypothesize racism as a fundamental cause of racial disparities in health. Okay, so what is racism? What do I mean when I say the word racism? I start out by saying that it is a system. So I'm very clear that I'm not talking about an individual character flaw, or a personal moral failing, or even a psychiatric illness, as some people have suggested, but I'm talking about a system of power. A system of doing what? It's a system of structuring opportunity and of assigning value. And on what basis is the opportunity structured, and on what basis is the value assigned? It is based on the social interpretation of how we look, which is what we call race in this country. I will stop in my definition for a moment just to say, look at me here. Here in Annapolis, I am clearly black. In some parts of Brazil, I would be just as clearly white. In South Africa, I would be clearly colored. So here with the same appearance, the social interpretation of my appearance in those three different settings would assign me to three different racial groups. And furthermore, if I were to stay in any of those settings long enough, my health outcome would probably take on that of the group to which I've been assigned, even though I'd have the same genes in all three places. So now, to proceed with my definition of racism, racism, I say, is a system of structuring opportunity and assigning value based on the social interpretation of how we look. What are the impacts of this system? Well, it unfairly disadvantages some individuals and communities. And when we think or talk about racism at all, this is where we go. It's not often enough in this country, but this is where we go. But it doesn't take very long to recognize that every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. And that's the whole issue of unearned white privilege, which we hardly ever talk about in this country. And even beyond that, even as we recognize that we have a system that's either unfairly disadvantaging or unfairly advantaging individuals and communities, racism is sapping the strength of our whole society through the waste of human resources. And this perhaps is the most important thing that we need to communicate in our data, in our storytelling, in our media. Examples of this include how racism and the blinders of racism that make us think that there's no genius in the barrios or in the ghettos or in the reservations means that we are not investing in the full, excellent public education of all of our kids. Of course there's genius in all of our communities, and if we were to invest fully in all that genius, we could be doing so much better as a nation or even as a world. We could be farming on Mars if that were a good thing to do, if we were to invest in all that genius. I could give you lots of examples of how racism is sapping the strength of all of this, but I'm going very fast, and so we're going to go on. So now, that was my global definition of racism. I find it useful as a health person to think about 3 levels of racism: institutionalized, what I call personally mediated, and internalized, to help us figure out how could racism be causing a difference in asthma prevalence between these 2 communities? How could racism be turning into diabetes? How could racism be causing this, that, or the other? So I'm going to briefly define each of these levels, give some examples, and then illustrate these 3 levels of racism with another story. I define institutionalized racism as that system that results in differential access to the goods, services, and opportunities of society by race. I'm so sorry back here that I'm keeping my back to you. You guys okay?
We got it.
You're okay?
Yeah.
So I'll keep doing like this. So institutionalized racism, differential access to the goods, services, and opportunities of society by race. This is the kind of racism that does not require an identifiable perpetrator. This is the kind of racism that is in our laws and in our structures. This is the kind of racism that often results in and is manifest as inherited disadvantage. And examples include differential access to quality housing, or equal educational opportunities, or equal employment opportunities, or even the same income at the same level of employment, differential access to medical facilities, or a clean environment. And in terms of power, differential access to information, could be health information, or information about our own histories. Differential access to resources, not just capital resources, but social networking resources, knowing somebody in the legislature. Differential access to voice in media and government and the like. Sometimes people stop me here and they say, Dr. Jones, housing, education, employment, income, you know, that's what we call social class. Why do you have that on a slide about racism? Is it social class or is it racism? This is a very important question, right? So I'm going to answer it. And the answer starts with the fact that it doesn't just so happen that people of color are overrepresented in poverty in this country, while white people are overrepresented in wealth. For each marginalized, stigmatized, oppressed group, there's been some initial historical insult. So for American Indians, it was the taking of the land and the genocide and the moving of the survivors to the reservations. For people of African descent, we've just had a whole discussion. I sometimes sum it up as the kidnapping, although I know it wasn't always kidnapping, it was trade. But the kidnapping of West African people, our importation across the Atlantic with tremendous loss of life in the Middle Passage, and then what I describe as the coerced usury of our unpaid labor for centuries to build this country. But then people stop me there and they say, well, Dr. Jones, don't you know that at least in the United States, the enslaved people were emancipated in 1865? Right? That's fully 137 years ago. All else being equal, don't you think the impacts of slavery would have washed out by now? But the key phrase there is all else being equal. And all else has not been equal since 1865, and all else still is not equal today. And there are still what I describe as contemporary or present-day structural factors in our laws and all, in the way that we fund public schools based on local property taxes, so then you're going to have poorly funded schools and another whole generation lost. In those things that are perpetuating the initial historical insults. So when people ask me, are you talking about racism? Or are you talking about social class? I say that institutionalized racism explains why we even see an association between social class and race in this country. And that's a very important insight, because as much as I would love to have a magic wand and equalize social class across this country today, I would do it if I had a magic wand. But if I didn't also pay attention to the background structures and policies and all that were set up to differentially shunt different populations into different opportunities, then within one generation, within 20 years, we would start to see a stratification again by race. We need to address all of it. And before I get off of institutionalized racism, I also need to say that often it shows up as inaction in the face of need. Was that my 20 minutes?
Can you repeat that?
Yes.
Often it shows up in what?
As inaction in the face of need. You know, you are so interested in that point. I have to say, I spent 8 months in New Zealand, and that characterization of institutionalized racism is also now written into the Waitangi Tribunal hearings when they were, I mean, they also really appreciated my framing of racism, and now that's part of their kind of legal stuff.
Thank you.
Yes?
You're just about done.
Huh?
You're just about out.
Well, I have about 5 more minutes, if I may. I mean, these other people also did.
Okay. About 10 minutes for folks.
No, yes, I'm watching. I need to get through these 2 levels very quickly and tell my story, and I will stop. So, personally mediated racism, you thought I was fast before. Person-mediated racism, differential assumptions about the abilities, motives, and intents of others by race, and then differential actions based on those assumptions. That's what most people think of when they hear the word racism. Somebody did something to somebody. It includes our prejudice, the different idea, the discrimination, the different action. Here are some examples. Police brutality, physician disrespect, which can be as subtle as a physician not giving a patient the full range of treatment options because that physician thinks that patient couldn't afford, wouldn't comply, wouldn't understand, or whatever they think. Or it could be quite blatant, like sterilization abuse, which has had many iterations. Shopkeeper vigilance, waiter indifference, teacher devaluation, very important. When a teacher looks at a young child and thinks that child can't learn and puts them off in the ADD track, that child will never even know their full potential, much less have the opportunity to develop to it. Like institutionalized racism, personally mediated racism can be through acts of doing, acts of commission, as well as acts of not doing, acts of omission. Right? But it's also important to say that it can be unintentional as well as intentional. You don't have to have intended to be racist to have had a racist impact. Internalized racism I define as acceptance by members of the stigmatized races of negative messages about our own abilities and intrinsic worth. Example, self-devaluation, the white man's ice is colder syndrome, resignation, helplessness, hopelessness. Wish I could give you examples, but we must go on. It's about accepting the limitations to our own full humanity of the box into which we've been placed. So now I'm going to illustrate these with a story. Basically, the key things of this story came from my own experience where my husband and I were planting flowers in some flower boxes in our home here in Baltimore. I used to live in Baltimore. And we went out to the boxes. Some of the boxes had some dirt in them already. Some of the boxes were empty. My husband brought gardening soil, potting soil to fill up the empty boxes. We put equal numbers of our marigold seeds in all the boxes. 3 weeks later, we see that some of the boxes are full of flowers. Other boxes just have a few scrawny-looking flowers. We recognize that that potting soil that my husband had brought was rich, fertile soil. Every single seed planted in the potting soil has sprouted, with the strong seed growing very tall and vigorous. The weak seed at least made it to a middling height. That old soil that we had found in some of the boxes was poor rocky soil. The weak seed planted in that poor rocky soil had died. The strong seed had to struggle just to make it halfway up. Then I saw this with my own eyes. It's a story about the importance of the environment, the importance of the soil. I'm going to make that image into a story about racism by introducing a gardener. So now I have a gardener with 2 flower boxes, one which she knows to have poor rocky soil, one which she knows to have rich fertile soil. And she has seed for the same kind of flowers, except some of the flowers are going to produce pink blossoms, and some of the flowers are going to produce red blossoms. And the gardener prefers red over pink. So she puts the red seed in the rich fertile soil, she puts the pink seed in the, she put red in the rich fertile, pink in the poor rocky. 3 weeks later, all the red seeds sprouted, the weak ones making it at least up here. In the poor rocky soil, the weak pink seeds have died. Here comes the strong pink seed trying to make it, and then those flowers go to seed. The next year, the same thing happens, and those flowers go to seed. And year after year, the same thing happens. Finally, about 10 years later, the gardener's coming and she's looking at her flower boxes and she says, you know, I was right to prefer red over pink. Okay, so that's we'll interrupt that for a minute to say that first part is how institutionalized racism works, where you have the initial historical insult of the separation of the seed into the 2 types of soil, the contemporary structural factors of the flower boxes keeping the soil separate, and then through inaction in the face of need, perpetuation of the inequity. Pick the story back up. Where is personally mediated racism? Gardner's looking at the red flowers thinking, oh, they are grand and glorious. She looks over at Pinky, she says, oh, they sure are scrawny and scraggly, so she plucks off the pink blossoms before they can even go to seed. Right? Or she might notice that a pink seed has blown into the rich fertile soil and she plucks it out before it can establish itself, which is some of the anti-affirmative action stuff that goes on. Where's the internalized racism? Well, the red flowers are in their box, enjoying being red, just living. Probably many of them not even understanding that they're benefiting from enriched soil. Pink flowers are looking at red, wishing with all their hearts that they too could be red. And here come the bees. And the bees are just minding their business, collecting nectar, but they're pollinating at the same time. So here comes a bee into one of the pink flowers, and into another one, and then to this other one. This pink flower says, get away from me, bee. Do not bring me any of that pink pollen. I prefer the red, because the pink flower has internalized that red is better than pink. So what do we do to set things right in this garden? Well, we could start by addressing the internalized racism. So we could say to the pink flowers, you know, pink is beautiful, power to the pink. And that's an important intervention. That's important, but if that's all we do there, it's not going to change the situation in which they find themselves. Or you could say, okay, let's address the personally mediated racism. So we could have a conversation with the gardener, or better yet, we're going to have a workplace multicultural workshop for the gardener. And in this workshop, we say, dear gardener, would you please stop plucking those pink flowers? And maybe she will, and maybe she won't. But even if she does, it's not going to change the situation in which they find themselves. What we really need to do if we want to set things right in the garden is to address the institutionalized racism, meaning we have to either break down the boxes and mix up the soil, or if you want to keep separate boxes, that's all right too, although it makes it easier going forward to keep segregating resources. But if you keep separate boxes, you need to enrich that poor rocky soil until it's as rich as the rich fertile soil. And when you do that, the pink flowers will flourish. They'll be looking beautiful, grand, and glorious. And when you do that, they will now, you'll have addressed not just the institutionalized, but the internalized. Because they won't be looking over at red, thinking red is better. And you may even address the personally mediated, because the original gardener may have to go to her grave preferring red over pink, but her children growing up and seeing the flowers equally beautiful would be less likely to have that kind of attitude. So this story is about these 3 levels of racism. The last thing on the story, who is the gardener? The gardener is the one I gave the power to decide, the power to act, and control of resources. In my mind, those are the elements of self-determination. Who is the gardener? Clearly government is the gardener. Clearly the Legislative Black Caucus of Maryland is part of the gardener, as are for media, as are foundations, as are corporations, as are communities, to the extent that they can have self-determination. But whoever the gardener is, it is dangerous when the gardener is allied with one group. I painted the gardener red, that's why she prefers red over pink, and it's dangerous when she's not concerned with equity, when she can look at those flower boxes and think that her garden is beautiful because she's not even counting the pink flowers as part of the boxes. So I will leave you with this challenge. What do we do about the gardener? Do we try to make the gardener polka dotted or striped or fuchsia? Do the pink flowers have to grow or recruit their own gardener? I just want to leave you with 2 last questions that have been raised in the discussion around this. One question is, I was once asked, why should the red flowers share their soil? That's a very important question. First, it shows the power of the story, because if we were talking about racism between me and you, that would never come up. But my answer to that is that soil does not belong to the red flowers, it belongs to the garden. The other thing that I want to say is that it is very important that we make those boxes transparent. We need to be talking not just about the different heights of the soils, but we need to be talking about the heights of the flowers, but the differences in the quality of the soil. That's part of my job as a public health person. So I must stop here. If you want to see any data later, then you can ask me.